to talk about this subject. It's a huge subject, so I'm afraid I won't do justice to it, but nevertheless, I think it's a very important one, which is the dialogue that we have and we need to have between our patients and how adherence potentially can affect healing. So I'm going to very briefly look at the factors influencing adherence and adherent behavior. Can we define this in some way? To look at the evidence, if we have it, of whether adherence is related to leg ulcer healing, and to explore some of the professional solutions. And then finally to look at some of the myths that I think are perhaps influencing our uptake of compression, and I would say quite clearly are influencing our outcomes overall in terms of the international arena. So adherence, the whole issue is a huge one. I could spend hours here just talking about this, but there isn't one nurse or one doctor I have met who hasn't said to me, I have huge problems with my patients doing what I ask them to do. So it's a very common phenomenon. Muir Gray, who was a sociologist many years ago, described the social ulcer as a group of people who simply did not want their ulcer to get better because they perceived a benefit from it. So sociologically, this is a very, very difficult area. But firstly, we should really think about what do we know. And firstly, we should understand that there is no such thing as a typical profile of an adherent or a non-adherent patient. There is no common denominator. And if you look at chronic illness literature, they will tell you that many factors, it's very, very complex. So we cannot simply look to identify the patient coming through our door and saying this patient is a compliant patient, a non-compliant patient, because it's very complicated. But in the focus of looking at compression, which of course, as you can imagine, I'm passionate about, I mean, simply without compression, leg ulcers will not heal, but we often forget the very important other factors that affect the patient and they affect their use of compression. So it's really, really important to not forget factors such as clinical depression. It's a phenomena that's very relevant in venous ulcer patients. 10% of patients have a clinically defined problem of depression, and this needs to be treated. Anxiety is an issue. Anxiety fluctuates. It's very, very common in the first episode of ulceration, but it increases if you have frequent episodes of cellulitis. So these are really, really important factors. And sleep disorder is, again, a common phenomena. If you cannot sleep because your pain is not controlled, and your compression, you believe, makes things worse, you're not going to adhere to treatment. We have a very complex issue about social support, again, a very, very complicated area. But some of the very practical things that we face as clinicians are purely about people's ability to manage compression. Not just during an episode of intensive bandaging, for instance, for an ulcer, but longer term. The reason why we have such terrible recurrence rates in the UK particularly is because there's no systems of care to actually keep these patients from actually having a new recurrence. And these are really big issues. We have the issues around what people believe, so what we call locus of control, the kind of patient who believes, well, you've come through my door, you get my ulcer better, and I have nothing to do with it. They have an external locus of control. The other sort of person is the person who takes control themselves, wants to understand that. And these things are absolutely critical when we're thinking about helping our patients to adhere to treatment, because the evidence is very clear. Reduced quality of life is the impact of having an ulcer. I'm afraid I'm going to go against the survey and say I absolutely want my patients' ulcers to heal, number one, because it will make all the difference to their quality of life. So as a UK nurse consultant, it's my priority because it's the only thing that I can kindly do to really help them. And of course, people don't just have one episode, they have many, many episodes, and they've got to adjust to this. All of these things are important, as well as the culture in which we're working, the country in which we're working, the patient's experience of their treatment, whether they perceive it to be beneficial. If you don't believe your treatment's going to work, why will you bother with it? And actually, that's a reality. For many of our patients with compression do not believe it's going to work. And sometimes the treatments we give them are not compression anyway, so no wonder they don't work. Their expectations of care, all of these things, again, lead potentially to issues of adherence and to conflict between patients and professionals, and ultimately as well, potentially to manipulative behavior. So again, I'm not going to spend long on this, but we've moved in our thinking from the old-fashioned idea of compliance, described by Sackett as being the degree to which the patient deviates from prescribed treatment. Paternalistic, I know best, do as the doctor says. And societal change has moved away from that to a feeling of more equality. Concordance is about the relationship with my professional, working with the patient, but far more importantly is adherence, the ability to stay with something and actually deeply embed that in your belief system so that you do carry on. And that's a real challenge for many of us. I did a systematic review some years ago to try and look at what evidence we had about whether there really was a relationship. And we did a systematic review looking at venous leg ulcers and whether there was any evidence from the RCTs and from real-world studies about whether there was a link to healing or not. And obviously, this study is old now. But what we found was surprising, that the rates of non-concordance with treatment in randomized controlled trials were between 2 and 42%. In real-life studies, it was between 10 and 80%. But when you did look at it, you could actually see that 50% of healing rates were reduced when there were problems with concordance, and the median time to healing was twice as long, and the recurrence rates were anywhere between 2 to 20 times greater. There's a caveat to all of this, because most of these studies have defined the patient as compliant or not. So this is a judgment made by a professional, which sometimes included, did I turn up at clinic or not? So it's a very, very complex issue to try and look at. I did a study in London where I was really looking at, could we really predict with any accuracy whether compliant behavior, as in sticking with the treatment plan, was in any way a predictor of whether I was going to heal or not. So this was a prospective study with nearly 100 patients. They had a blinded assessment of their healing, carried out separately to a blinded assessment every month of their concordance behavior. The study did not find that levels of concordance correlated well with healing. The professional definitions of concordance are not useful to predict healing, and we need lots more research on this to try and understand this more. But I can tell you that professional labeling of compliance is extremely complex and usually suggests when you're using that behavior that you're actually dealing with a difficult patient who you find difficult. So it's very complex. Why is it important? Well, it's very important because well-being and adherence go together. Living with a wound can impact on lifestyle profoundly. It changes people's priorities, their behaviors. We know that psychological factors deliberately delay healing. So depression, pain are independent risk factors associated with healing. We focus on ulcer duration, ulcer size, they're very important, but there are independent risk factors, psychological ones, associated with delayed healing. And if we do not control our symptoms of our patients, how can we therefore expect them to manage compression? And this is, again, a really, really important. And the evidence is when we involve our patients, they have greater control and outcomes are improved. And again, there's a strong economic argument underpinning this as well. So ideally, we want a shared approach. We want to work with the individual to identify their concerns from the moment they come into the door. And work with them to understand that, and that's very important. We want to engender adherence through empowering them, giving them choice, helping them to understand there is choice, and they are part of that program. And there's also about shared decision-making, which sometimes is about accepting the decision is not to have compression. And an informed patient is also very important. So I always think that the most important thing as a clinician is to view that individual as a person, but to prioritize adherence, absolutely. I'm afraid I'm very black and white with my patients. If they come into me and they have a venous ulcer, I say to them, if you come in and you're a diabetic and you need insulin, I don't give you an aspirin. If you come into me with a venous ulcer, I give you high compression because I want to make you better. We're far too soft in our thinking about compression, and it's not helpful to our patients. And we need to involve them genuinely in their care and respect the wishes and the rights that they have as well. So finally, just to dispel some of the myths, when I look at how I've been around a long time, unfortunately, but when I look back 30 years, how much have we really moved? The idea that low compression is better than no compression in the systematic reviews is wrong. It is not sufficient. High compression is what heals venous ulcers, so I really want to get that message across strongly. If you do not provide an adequate level of compression, you do not treat their symptoms, you do not get their leg ulcers healed. It's black and white. You, of course, have to treat the patient individually, but you must get the right level of compression. You need a compression system that has proven evidence, and that's absolutely essential. There's a lot of fear that somehow compression is very, very dangerous. My patient's leg is going to drop off from critical ischemia. Absolutely not true. Compression is safe right down to the point of critical ischemia. And of course you need to use an evidence-based system. You need to know how to apply them. But if you do not control venous hypertension, you actually make somebody with concurrent arterial disease slightly worse. So actually failing to use compression, it's a myth to suggest it's dangerous. The idea that if it's painful, I should remove my compression, not true. Pain is a phenomenon of ulceration. If you look at the Kaplan-Meier curves, you actually see pain does increase when you first apply compression, and you see it drop off beautifully after a few days, because you're reducing the inflammatory mediators, and you're reducing edema, and pain gets better. And patients will not tolerate compression. Not the case. They do tolerate compression if you're giving them tailored compression for their needs, and they can do very well. The idea that venous ulcers do not heal, well, I still very much dismiss it, because I'm working in community settings and I'm still able to achieve a healing rate of 75%. So there's other reasons that are influencing these terrible healing rates that we see in so many countries. And with a good evidence-based system, you're in a symposium with the K2 system, which is a brilliant one. So if you're using an evidence-based system, from my perspective, there's no reason why we should have low healing rates. So in conclusion, Mr. Chairman, ladies and gentlemen, for me it's important to involve our patients in a holistic approach, communicate with them, share the evidence and share the goals with them. And don't believe the compression myths that somehow this is dangerous. The right compression with effective local care is the way in which we're going to achieve ulcer healing that ultimately is going to change quality of life and be cost effective. Thank you.